I am Dr. Benjamin Levy. I'm a thoracic medical oncologist at Johns Hopkins School of Medicine, and maybe we can just go around the room and introduce one another.
My name is Dr. Wally Kern. I'm a radiation oncologist. I'm the Chief Medical Officer for Genesis Care, and I'm also Professor Emeritus at Emory University.
Hi, I'm Michelle Ginsberg. I'm Director of Cardiothoracic Radiology and Vice Chair for Education at Memorial Sloan Kettering Cancer Center. And I'm also a Professor of Radiology at Weill Cornell Medical College.
Mike Lanuti. I'm a thoracic surgeon at Massachusetts General Hospital in Boston. I'm the Director of Thoracic Oncology for our Division of Thoracic Surgery. Also have an adjunct associate professor at Harvard Medical School.
I'm Ramaswamy Govindan, a medical oncologist with interest in lung cancer. I'm a professor of medicine at Washington University in St. Louis.
This is a 50-year-old African-American male, former smoker, with newly diagnosed stage IV adenocarcinoma, the left lung, harboring an EGFR mutation, with spinal cord compression and bone metastases. And question is, what systemic agents are recommended in this case? And is there a role for additional radiation? So patient presentation: presents with lower back pain after picking up a bag in the grocery store in mid-September. The x-rays were normal. He proceeds to physical therapy with no relief of symptoms, seeks care with a chiropractor. The pain worsens. He eventually gets an MRI of the spine that reveals diffuse osseous lesions, and the patient is referred to the emergency department. He has a performance status of 0. No past medical history. He's a former smoker, but quit 30 years ago. He had a 6-pack year history of smoking, so a light smoking history, social alcohol use, family history consistent with a father with prostate cancer. We don't have the imaging here, but the CT scan reveals multiple pulmonary nodules, with the largest of the left lower lobe measuring 3.3 centimeters. He's got some hilar and mediastinal adenopathy. He has a T8 compression fracture, which may be explaining some of his pain. He has large lytic lesions at C1, L1, L5, and a pulmonary embolus in the right upper lobe and right middle lobe. The MRI of a CTL spine just shows diffuse osseous disease. Is a C1 lytic destructive lesion involving the left lateral condyle, and then has severe cord compression at T1, L1, and L5. He gets a biopsy of the left lower lobe nodule. That's adenocarcinoma. That's EGFR positive. The MRI was negative for intraparenchymal lesions, but shows a 2.8 centimeter calvarial lesion. Unfortunately, this is quite a common scenario for us for these patients presenting with widely metastatic disease, specifically in the bone, which remains a problem with vertebral metastases and cord compression. Patient gets 8 fractions 24 gray of plan 30 gray and 10 fractions of radiation to T8. During treatment, his back pain worsens. He gets a spinal fusion of T8 performed by neurosurgery. And after completing rehabilitation, he meets with medical oncology, who recommends osimertinib. So before we get to the systemic agents that are recommended in this case, maybe we can talk about the role for radiation. Is there, the patient didn't get all planned doses of radiation to, I believe, T8. Is there a role for radiating other sites as well? Dr. Kern, I'll put the ball in your court first to discuss the radiation options for this patient.
Yeah, thank you. Yeah, it sounds like a very bone-seeking, aggressive lung malignancy. We heard a summary that at 2 other locations there was severe spinal cord compression and large lytic lesions in the cervical spine. So it would appear to me that the identified cervical and lumbar area need to be irradiated. There's not going to be a whole lot of other opportunities to intervene before he becomes compromised. Anytime you have to interrupt radiation to do a decompressive infusion, you do wonder whether that should have perhaps been the initial approach. Perhaps do the spinal cord decompression at T8 initially, and then radiate that as well as the other lesions. In terms of additional radiation, probably not a bad idea. Many times the spinal surgeons really want us to wait quite a while if they are doing grafting. So whether it benefits or not, it's hard to know, but I'm assuming there was a lot of aggressive disease, and long-term it'd be better if you could do some additional radiation there, but probably more importantly, treat the untreated areas.
Okay. Dr. Govindan, what do we generally recommend for these patients? I'm assuming this is an EGFR common sensitizing mutation. Doesn't say that, but let's assume it's a 19 or 21. What would you recommend? And would you also recommend a bone strengthening agent as well?
Yeah, I think it's fairly straightforward in the presence of sensitizing mutations like exon 19 deletion or L858R. Osimertinib is the appropriate agent. I would consider denosumab or zoledronic acid given the extensive bony metastasis present here. It offers only a modest benefit, but I think if ever there's a situation to use it, perhaps here it is one. And one thing I want to quickly point out is that addition of other agents like chemotherapy, bevacizumab to osimertinib in the frontline setting is in an investigational approach. Also, I would urge practitioners to keep this in mind that there is absolutely no role for combination therapies with a checkpoint blockade with EGFR inhibitors. They are disastrous, they cause lung toxicities, so it should be avoided.
Great points, and clinically relevant ones, given we see these patients frequently, and oftentimes we want to treat these patients with immunotherapy, but for these driver mutation patients, we certainly want to pump the brakes on that. So final recommendations here are to consider treating the untreated sites of disease in the spine. Correct me if I'm wrong there, Dr. Curran. And also consider some additional radiation post-surgery for that T8. And then osimertinib would be the standard here without any combination chemotherapy or bevacizumab, and certainly not a checkpoint inhibitor.